Hello everyone, my name is Nur Shahida binti Muhammad Najib and I'm from BC. The heart's conduction system is the electrical wiring that controls how the heart beats, coordinating the right and left chambers so they pump blood enough. But the conduction system involves both the right and left sides of the heart that are working together. So here, the overview of the conduction system of the right sides. Okay, so we have SVC, ascending aorta, SA node, posterior and anterior internodal tract, pulmonary trunk, AV node, trunk of AV bundle, also known bundle of His, RBB of atrioventricular bundle, and the last one subendocardial branches. The other name is Purkinje fiber. We move to the left side of the heart. So here the overview of the conduction system of the left sides of the heart. Okay, so we have SVC, same as the right sided. Left bundle branch of AV bundle, subendocardial branch, also known Purkinje fiber for the left side. Aortic arc, pulmonary trunk, same as right sided, and trunk of AV bundle, also known bundle of His. Let's explore how the heart beats powered by its electrical conduction system. It all starts at the SA node, now as the natural pacemaker, is generate the first electrical impulse, causing both atria to contract and push blood into the ventricle. Next, the signal reaches the AV node, which delays the impulse just enough to allow the ventricles to fill. So from there, the impulse travels through the bundle of His into the right and left bundle branches along the interventricular septum. These branches carry the signal to the Purkinje fibers, which rapidly spread the impulse through both ventricles, causing a strong and synchronized contractions. This is what pumps blood to the lungs and the rest of the body. The entire cycle repeats with each heartbeat, and we can track it on ECG using the P wave, QRS complex, and T wave. This amazing conduction system keeps the hearts beating in perfect rhythms, about 1,000 times a day. So here is ECG timelines that are correlated with the conduction system of the hearts. So we have P wave, atrial contraction for both right and left sided. Then QRS complex, ventricular contraction for both right and left, and the last one, T wave, is ventricular repolarization. What's happened when the heart's rhythm goes out of control? Welcome to the world of atrial fibrillations, a common but serious heart arrhythmia that affects millions worldwide. Let's dive deep into the anatomy, physiology, ECG correlation, and clinical significance of AF. Atrial fibrillation, or AF, is a supraventricular tachyarrhythmia characterized by uncoordinated atrial activation leading to inactive atrial contractions. Instead of a single, coordinated wave of electrical activity from SA node, multiple small wavelets circulate randomly within the atria. Now I'll be talking about the ECG findings. ECG is a key to diagnose AF. The above ECG stripes shows classic ECG features of AF, which is no P wave due to no coordinated atrial depolarization. Second, irregular rhythms. Third, irregular RR intervals, making it hallmark of AF. The last one is vibratory F wave, which is fine random baseline undulation and best seen in lead V102. Then below we have three types of AF based on ventricular response. First, AF which RVR, rapid ventricular response, that means ventricular rate more than 100 BPM. On ECG we saw fast irregular QRS complex, no P wave. In AF which RVR, the AV nodes conducts too many impulses. The heart races, increasing myocardial oxygen demand and reducing diastolic filling time. Second, AF with CVR, control ventricular response. That means ventricular rate is within 60 to 100 BPM. On ECG, we saw irregular QRS consistent with AF, but heart rate is within normal range. Control response means the heart rate is within normal limits. is often achieved through medications like beta blockers or calcium channel blockers. Last one is AF, which SVR, slow ventricular response. That means ventricular rate is less than 60 BPM. On ECG, we saw irregular QRS, no P wave, slow heart rate. A slow response in AF can be just as dangerous, leading to poor perfusion, syncope, or worsening heart failure. But in many cases of AF, we almost seen AF which RVR, rapid ventricular response. Here I explain a systematic 10 steps ECG intervention. First step is speed. Speed usually 25 mm per second and usually right down below here. Then we must be able to recognize either the rhythm is sinus or not. So see at long lead 2 here, there is not sinus rhythm because no identifiable P wave before QRS complex. So this is consistent with the AF atrial fibrillations. Third, rhythm is irregular or regular. So as we can see here, the rhythm is irregular because the RR interval is not the same. Then the third step is calculate the heart rate. So to calculate the heart rate within the irregular rhythm, we must use the 6-second method, which is we count how many QRS complex within 6 seconds and then times with 10. Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 20, 21, 22. So 22 times 6, we get 220 beats per minute. This indicates tachycardia and indicates rapid ventricular rates for AF. Then the fourth step is we must see on the axis, see on lead 1 and FVF, positive and positive. That means normal axis. Fifth is P wave. So for the P wave, as I mentioned above, there's absence of P wave. That means no organized atrial activity. Instead, a vibratory baseline is seen in some leads. Then PR interval. As we can't see P wave, so the PR interval is not measurable. Then QRS complex. The QRS complex is narrow because of the supraventricular origin of rhythms. The normal QRS complex is 0.08 to 0.1 second. Then ST segment. As we can see here, no ST segment elevation or depressions. Then T wave. For the T wave also normal. And the last one is the QT interval. It's difficult to assess accurately due to irregular rhythm and high heart rates. So we can see here no obvious QT prolongations. Okay, for the second ECG, the same step applied as previous. First, speed. Speed is 25 mm per second. Second, able to recognize either is sinus rhythm or not. For this ECG, it's not sinus rhythm because we can't see P wave followed by QRS complex and T wave, and the rhythm is irregular as the RR interval is not same. Okay, third, calculate the heart rate. Okay, so despite to the irregular rhythm, so we must use the 10-second method. So we count the QRS complex and times by 6. So 12 QRS complex times 6, so we get to 72 beats per minute. So it's the normal heart rate. Then the number 4 is axis. Axis look at lead 1 and AVF. Positive, so normal axis. Then P wave. P wave, as I mentioned previous, is absent, so it's replaced by fine vibratory F wave. Then PR interval. As we can't see P wave, so PR interval is not measurable. Then QRS complex. So the QRS complex is narrowed. It indicates supraventricular origin of impulse. And then ST segment. There's a mild ST depression in lead V5 and V6, possibly secondary to rate or non-specific changes, and no acute ST elevations. And for the T wave, some T wave inversion or flattening seen in lateral leads. And then QT intervals. QT interval is normal. For the third ECG, use the same method as previous. First, speed 25 mm per second. Second, this ECG is not sinus rhythm and rhythm is irregular. And third, calculate the heart rate. So the heart rate is 36 beats per minute. Fourth, axis is normal. Fifth, there is no P wave. Sixth, PR interval is not measurable since there is no P wave. And then narrow QRS complex. Next, ST segment is also normal. 9 T wave are also normal. And the last one is the QT interval. QT interval appears slightly prolonged. So here, the causes of the AF, which is first, open heart surgery. Second, pulmonary hypertension. Third, holiday heart syndrome, means excessive alcohol intake. And the last one is hyperthyroidism. So for the symptoms and complication of AF is palpitation, fatigue, shortness of breath, and the complication is CVA or brain stroke or MI or heart attack. Next, for the treatment is first, rate control, which is beta blockers and digoxin. Second, the rhythm control, which is cardioversion and catheter ablation. And third, anticoagulation, which is DOACs and the warfarin.